A couple of things out of the presentations that I've heard so far. First of all, I was trying to think back to my growing up in Calgary and playing hockey once upon a time, where I would have ended up as a character or a role player, and I think with my size and my limited skating ability, I could aspire to goon. So I'm glad I went a different direction in life. The second thought was that, I heard the word transformation a number of times this morning. And it got me thinking that, it's really hard to increment your way to transformation. And my organization at the national level has had, I think, two, if I had a little bit more time, I might come up with a third, but I can think of two off the top of my head, two transformative moments. And one actually took place in 1954, which was a constitutional agreement between our health plan and our medical groups that laid out division of responsibilities and accountabilities and everything else that survives to this day, and what makes us actually unique in American healthcare and in perhaps even globally. And then the second was a decision about 15 years ago with our then new CEO, George Halverson, coming in and deciding to basically write off about $500 million worth of health IT investment and say, we're a healthcare delivery system, we are not a health IT company, and we're going to contract out and we're going to have someone else, in this case Epic Systems, install our electronic medical record. And we did that on the basis of thinking we could transform the quality of care that we delivered. And I think we greatly underestimated what it has allowed us to do. The thought at the time, and I'll talk about this a little bit more, was that you want to be able to have right information for the right patient at the right time in the office. And in fact, 15 years later, we're able to do things in population health terms that almost no one else can do. We're able to do things with virtual care that almost no one else can do. And I don't think we fully grasp the capabilities there. And that's one of the building blocks for how we drive for value. And I want to say here, I'm using the term driving for value, and that's maybe broader than driving for efficiencies. It's broader than just quality improvement. It is, can we get more from the resources we put in? And I'll try to get some examples. For my talk, I want to give you a little bit of background on the structure and the composition of Kaiser Permanente. It's important because a lot of what we can do relates to that structure. And also, we are, for those of you who are exposed to the American healthcare system or have followed it with amusement and horror over the years, we are kind of the opposite of most of American healthcare, and we have a lot of reverse economics built into our system. And it's important thinking about that to say, could we do that? Well, here's the building blocks you have to have. Then the second is I will talk about some of those building blocks that allow us to drive for value and talk about the science and the art and the environment in making that happen. So the first test for somebody is always, can you work the clicker? Yay. In lay terms, what is Kaiser Permanente? I say in lay terms because I'm going to give you some visuals in a second that may or may not help you. But we are a leading healthcare provider and not-for-profit health plan. We don't use the term health insurance company, but we do compete in health insurance markets, and our competitors are health insurance companies, but we like our own language. We're a health plan. But we bring together healthcare services and insurance coverage. We do most of this under one roof. Typically, our care locations are campus-based, and there will be a hospital, and there will be a number of outpatient facilities. We have a lot of other satellite stuff, but it's, for the most part, and particularly in California, where about 3/4 of our members live, it's one-stop shopping. And we're relentlessly team-based. You have a primary care physician, but all of the people talk to each other that need to talk to each other. All of the people who need to have the information for your care have access to that information, subject to HIPAA and other requirements. But it's available, and you're not wandering across town. I share the story. It's pretty dated now, but when I first came to Kaiser out of government, my older son has a number of special needs, and I realized we were sitting in an office where his psychiatrist and his psychologist were sitting next to each other. His neurologist was on the phone, and his electronic medical record was up on the screen. And I thought back to my days in Washington when I belonged to an insurance company that I would have been flipping through their preferred provider directory, looking under PSY to figure out what it was we needed. And that's just an anecdote, an N of one, but it really struck that they're working together on this, and that's important. Just by the numbers, to give you a little bit of scope, we take care of just over 10.5 million people. That's going to jump above 11 million in about 3 weeks. We have merged with Group Health Cooperative, and we'll be taking care of people in Seattle and Spokane, and finally closing that I-5 corridor from British Columbia to Tijuana. 19,000 physicians, 190,000 employees, of whom about 50,000 are nurses. We own and operate 38 hospitals. I think 34 of them are in California, a couple in Portland, Oregon, one in Honolulu, and then in our smaller regions out on the East Coast and in Colorado, we do not own a hospital. We have a lot of other facilities. This might be the last time you see this slide, because we've been talking so much about virtual care lately, and I said, why is it that the first thing we do is we go out and brag about how many hospitals and outpatient facilities we have? So it's just to give you an idea of scale. It's not to say the bricks and mortar are what we take pride in. Our mission: to provide affordable, high-quality healthcare services, and the critical word italicized there, and to improve the health of our members and the communities we serve. So we are a healthcare delivery system, but we're also a community health system, and trying to go upstream in a lot of areas. So I occasionally tell people that there's no such thing as Kaiser Permanente. What there is a trade name, Kaiser Permanente Medical Care Program, and it is composed of three entities, or three types of entities. Our health plan in each of our markets, we operate a local health plan that rolls up to our national Kaiser Foundation health plan. Kaiser Foundation Hospitals, which owns and operates the hospitals we have, or contracts with community hospitals. And then in each of our geographies, there is an independent, self-governed Permanente medical group. That is an organization of the doctors, by the doctors, for the doctors. They own it, they manage it, and physicians are salaried employees of the medical group. And I guess the simplest way to summarize the division between the two is my CEO, Bernard Tyson, head of the health plan, cannot fire a physician. So there's a lot packed into how we have a relationship between the health plan and the physician, which could occupy a lot of time here. But essentially, this allows a division of labor where health plan is the funding entity competing in health insurance markets to bring in premiums for our employer group customers, dealing with Medicare and Medicaid and other public programs for people getting their coverage that way, and then running the insurance benefits. And then the medical group is responsible for provision of medical services and holds financial risk for a good chunk of that. Slightly more complicated schematic: revenue coming in from health plan members, whether it's paid for by their employer or the government, goes to the health plan, and then resources flow either out to the Permanente medical groups. We have annual medical services agreements that we sign, and they take capitation, and then they're on the hook for the care they're providing, and then to the hospitals who get operating budgets. So what does an integrated model mean? First of all, it's shared responsibility. We talk about our organization being owned jointly by physicians, the health plan, and our labor partners. Another way to put that is my colleague Sharon Levine came up with the term shared fate model. We sink or swim together. I came up with this thing called the memo relationship, which I should, again, probably also delete. It stands for mutually exclusive, monogamous, and ongoing. And it finally dawned on me that maybe mutually exclusive and monogamous are kind of the same thing. But I was trying to convey more it's not serial monogamy, it's lifelong monogamy. Anyways, Kaiser Foundation Health Plan contracts only with Permanente medical groups. Permanente physicians only see Kaiser Foundation Health Plan members, other than people coming into our emergency departments. This creates an aligned accountability along multiple dimensions between financing and medical care. And now I want to be clear, it's not aligned on the day and the week and the month. It is aligned in a larger sense. We, at the beginning of the year, or I guess actually in sort of Q3 and Q4 for the coming year, We have a pretty good idea. We know what our public programs are going to pay us. We know the bids we've submitted to the exchanges under Obamacare. We know the rates we've negotiated with our employer customers. So we have something pretty close to a global budget. And at that point, it's figuring out how do you divide that global budget, what fraction goes to the medical groups, what fraction goes to IT investments and philanthropy and other kinds of things. We have alignment along the health and illness continuum. So the same people who are treating your heart disease are also it's the same system that 10 years earlier was telling you to diet and exercise. We have integration across healthcare providers. We are primary care, we are specialty care, we are person focused, not organ system focused. And we have alignment over time. We've been in business for 75 years. We are building hospitals, or have been building hospitals, with the presumption that we will be in business 50 years from now. We're looking at members who come in. We used to do, as part of some of our grassroots work, you'd go out and talk to people working in regional congressional districts, and they'd say, oh yeah, I've been a member since 1962. And I said, well, there's not much I can come and tell you about Kaiser at this point, but we have Kaiser babies growing up to become Kaiser members through the Medicare program. And then the integration means collaboration, but with functional specialization. Again, this is in stark contrast to much of the rest of U.S. healthcare. It's physicians practicing medicine, nurses caring for patients. They're both caring for patients, obviously. Health plan executives are not practicing medicine and are not interfering in medical decisions, and instead we're managing finance and administration and doing the other kinds of things. That again is an important distinction. The first managed care revolution in the United States 20 plus years ago basically foundered on the rocks because insurance companies were getting in the faces of physicians and trying to tell them all sorts of things around prior authorization and second opinions and everything else, and it just caused a lot of friction and a lot of resentment. In our case, physicians are making the decisions. I'll come back to this in a little bit. They're not doing it in a completely sort of medical office without walls, but there's definitely accountability there, but it's not having the health plan looking over your shoulder. So the building blocks here: alignment of incentives and mission. And I realized, I looked at this bullet, and it's no one's income depends on volume. Nobody in the care delivery part of the organization, none of their incomes depend on volume of services provided. Our people in marketing and sales, their incomes depend very much on bringing in, but that's volume of people, that's not volume of services. We spend a lot of time on evidence development, evaluation, and implementation to inform our clinicians. That's not for coverage decisions, that's to make care decisions. So health plan does not decide to cover device X or pill Y unless we're contractually obligated to do it. In fact, those decisions are made at the point of care. The other building block, again, is our comprehensive electronic medical record. Again, it's not just that you have access to real-time patient information, it's that you also have embedded clinical decision support. And this, of course, is clinical decision support tools that we developed internally. These are our guidelines that we're bringing to our physicians and our patients. And then the data to support to do population health. And I'll just do one quick digression on this because it's one of my favorite themes. And so much of the discussion, at least in the US, around electronic medical records is one person at a time, one doctor at a time. Do we have that right bit of information? And we talk about primary and secondary use. In fact, the real bang for the buck is in the so-called secondary use, where you're actually able to look at all of the people in your population. You're able to look at geographic variation. You're able to look at disease types. Whatever you want to look at, you can do it if you've coded it appropriately. And I just give some examples here. And I see various cameras. I'm happy to share slides, so you can get you can get these directly. But we use this. We can track safety and performance issues. We can do it to test new methods of delivering things. I'll give an example because it's one of my favorites. It's a small version of transformation, but for a number of years we were hitting a ceiling on our colorectal cancer screening because we just couldn't get people to come in and get their colonoscopies. And that ceiling was well below our target. And it turns out that just sort of yelling louder and sending more frequent reminders still doesn't make people want to get a colonoscopy. And, so instead we decided to go a completely different route, and that was to go with fecal occult blood test kits that you have to do annually instead of every so many years. And I won't go through the whole example here, but just cutting to the chase. By changing the approach we wanted to take to screen for colon cancer, we've now got the results of we're getting better clinical results, fewer deaths, fewer distant cancers, happier patients who don't have to have colonoscopies, they don't have to drive in, they don't have to make a co-payment. It is the triple aim in action. And we know it worked because we can track it all through our electronic medical record. We do a lot of work in research, and I'll talk a little bit more about this, but it's beyond the clinical trials. So, the safety issues with Vioxx were known. We were a participant in the original clinical trial, but the real issues came up later as we were able to look at it in actually real-world use and observe more significant risks than what were showing up in the clinical trials. We'll be the first to have extensive clinical results on the new hepatitis C treatments, right? So there's a lot of hype on this is the cure, this is the cure. So what happens when you actually prescribe that drug for a couple 100,000 people and then track them over time, and what do we know about that? A lot of ability to leverage natural variation. So across our program on the health benefits side, people have different co-payments, they have different deductibles. We can look at their adherence to medications. Calciprese, people who have higher deductibles and higher cost sharing are not as adherent on their prescriptions. But you can think then about changing things and what do you do? That's not transformation, but that's tweaking at the margin to make things better. And I put health equity in here because it's important to our organization, it's important to me. For many years, we assumed that because we treated everybody, we didn't have any disparities in our population. And because we couldn't measure those disparities, we could just maintain that hypothesis and go forward. Once we have the data, we can now look and say, what are the outcomes like for different populations, vulnerable populations, cultural differences, at risk, whatever. And we can now develop programs to say, look, we're seeing differences here. We need to do this. We need to do something different, whether it's language competency, cultural humility, whatever it is. Again, that's what having the data allows you to do. So who influences the value discussion for us? Obviously, it's our customers. It's the public programs. They don't negotiate with us. They tell us what we're willing to pay. That becomes the budget that we have to operate in. It's our environment. We go to market. So of our almost 11 million people, about 8 million are coming to us through health insurance markets of one sort or another. We have competitors in those markets. We have to be delivering something better than what they're delivering and at a competitive or lower price. You get the usual, and seeing a lot of this lately, noise emerging from the political environment that does or does not like what you've been doing, or if you refuse to cover or to do an experimental treatment, it gets into the press, and that's important. You guys feel those same kind of pressures. Ourselves, I think it's safe to say that almost everybody at Kaiser Permanente is a natural resource steward. None of us like wasting money. We all want to sort of optimize what we can get from the resources we have. That operates on the care delivery side, it operates on the health plan side. So how do we drive performance improvement? The first thing to note is that we have and have had a real culture of performance improvement for decades. On the physician side, long before we had an electronic medical record, we had shared medical records on pencil or pen and paper, where whatever you wrote in the medical record would be viewed by the next person that saw what you prescribed or what you noted. And there was a relentless trying to convert that into, and in a very labor-intensive and expensive way, how do we convert all that stuff we had on paper into something that we can use at the larger organizational level? But there's just there's artwork in some of our buildings that shows those old little handwritten spreadsheets on trying to measure what are we doing here. That's just it's just in the DNA. Shared and individual accountability. I sort of describe it as all of our physicians take the Hippocratic Oath like any other physician, but they're also responsible collectively for the population that their medical group is treating. Again, the medical group's self-governed and self-managed, and effective and committed leadership. And I should just note on the medical group side, the leaders are elected by the boards of the medical groups. But there's a real, that's at the very top, the sort of the CEO level of the medical group. But within the medical groups and within health plan, frankly, there's a real culture of how do we find future leaders, how do we groom those future leaders. It's about engaging with physicians. We run joint programs. We're doing it now with Harvard. We did it with the University of North Carolina for many years. We send our emerging leaders together to get these sort of executive MBA courses because you know what? The doctors need to be able to read spreadsheets. They need to be able to understand ROI. They need to be able to understand all the stuff the technicians are telling them around budgeting and be able to process that and make sense of it. And it makes a difference. So I'll just, a couple notes on sort of driving value, the science, the art, and our environment. When I say the science, I mean the information collection, the stuff that you can just do, and the reports that you can create. So you can gather research, you can use that to develop guidelines and set goals, you can design and develop care management programs. All of this stuff, I don't want to say it just happens, because it's actually pretty hard work, but it is the stuff that you have to start with. You have to have the data, you have to have the analysis, you have to have the recommendations. But that by itself doesn't actually get you anywhere. Somebody actually has to then put that into place and manage to it and monitor it. But I'll just give you a quick tour through what we do around assembling evidence. And again, this is a function of our scale. We have both the necessity and the luxury of having a number of organizations within Kaiser Permanente to scan the literature, to scan the market, to keep an eye on the pipeline for new technologies that are emerging. Our total joint registry is an example of something that we run through internal data to see how are we doing on hip and knee replacements, what do our revision rates look like, what is the performance of different devices that we're purchasing. External technology assessment, we can't always do everything or have the expertise to do it all in-house, so we rely a lot on the tech assessment vendors. Where there isn't evidence, we have a lot of capability in-house. We have research centers in each of our geographies. The collective numbers are somewhere around 1,000 staff. Many of them are practicing clinicians. A lot of work, a lot of NIH funded, and a lot of Kaiser Permanente funded research going on. We have the Kaiser Permanente Research Bank in Northern California, which is combining basically DNA samples along with the electronic medical record and various geographic and other characteristics. It's still in early days there, but it's going to give us a richness of data that I think is close to unparalleled. There's larger, and the UK is one place. I guess there are larger DNA banks out there, but they don't map back to the clinical information and historical information that we can do. And then we have a Center for Effectiveness and Safety Research, which is our ability to do comparative effectiveness research and to network across all of our individual research centers. That is a challenge. As soon as you get into the somewhat academic environment of research, it's always a little bit harder to get everybody to play well together, and we see a little bit more of our tribalism crop up, but we're getting better at it over time. So you have evidence, how do you evaluate it? I just give an example here of a couple structures that we have in place. Our National Product Council, which sort of is responsible for deciding everything we buy, from hospital beds to gowns to durable medical equipment, and it's taking in all the information from various sources, again, to try and negotiate the best deal. I should just say something on there too, because it applies for the National Product Council as well as for our P&T committees. So we have formularies for pharmaceuticals, we have formularies for devices. Those aren't just lists of things we will pay for or things we won't pay for. Those are very deliberate strategies to create competition in the manufacturer market. And because we have extraordinary, again, my colleague Sharon Levine calls it clinical discipline, prescribing discipline, we're able to move market share. So it's not that we're big. I mean, we're big in the 10.5 million people sense, but we're only 3% of the U.S. population. But we can basically change prescribing patterns overnight where we have a competing product, and that gets the attention of the manufacturers, again, whether it's in the device space or whether it's in the pharmaceutical space. Our Interregional New Technologies Committee is roughly the equivalent of a P&T committee for new devices and other things, and it's about doing the tech assessment, it's about doing the comparative effectiveness assessment, it's evaluating safety and effectiveness. And I would note, I didn't put it in here, but these things are co-run, co-led by both health plan and medical group, but if you look at the composition of them, the P&T committees, I think, are exclusively physician, and the Interregional New Technology Committee is probably about 80% physicians, and then the rest sort of legal and ethics and a few others. So talk earlier about having physicians involved in decisions. Our physicians are heavily involved in decisions. They are making the decisions. And I couldn't put a copyright on this since I stole it from somewhere, but in the Antarctic land of black and white penguins, why on earth would you ever spring for color film? And it's such a nice statement of, we want to pay for what we want to get. We had a manufacturer approach us a couple of years ago with sex-specific knee implants, and you can understand where that might make sense, certainly for hips, but it was a question of whether it made sense for knees. And we said, well, we're willing to try it. We won't pay more for it until we know whether it makes a difference. So if you give it to us at the same price you're giving us your unisex implant, we'll try it and we'll see what happens. We tried it, we saw what happens. It made no observable difference that we could detect in revision rates or patient satisfaction. And we said, we're fine with what we have. But they're out there advertising this or that product that they always sound good. But again, we have the capacity to say, well, we'll try it, we'll measure it, we'll look back on it. And if we don't see those claimed benefits, then we're not going to spend more for it. So I think I saw a lot of these bullets already today on other slides, but this is what I would term sort of the art of driving value. It's not enough just to have information and to have metrics in place and all of these other pieces. It's how do you get the human beings you want to achieve those metrics and do what they're supposed to be doing. In almost everything we're doing, we're starting with physician leadership and clinical expert champions. Our implementation of our electronic medical record that was this was a 5-year, I think it was originally supposed to be 3 years and $3 billion. It ended up being 5 years and $4 billion. So real money, real effort. But it started in every medical center and in every specialty of having a clinical champion that in persuading physicians that this is what we want to do. It's not about sending the IT guys out there. It's not about doing it by fiat and saying, on July 1, we're rolling over to this new system, good luck with it. It's about getting them to adopt. And actually one of our clinical leaders at the time, she has since retired, wrote a book on this whole process. And I thought it was going to be how I spent my summer vacation soldering wires together to put the electronic medical record, but in fact it was all about, this is a big change project, and a successful one. And the summary I like on it, again, in the KP Health Connect space, there's a quote from one of our physicians who said, it's not that the electronic medical record makes more work for you, it's that it makes very clear what your real workload is. And this is what you should be doing for this patient. Oh, you're not doing that, you don't have time or whatever. It didn't make more work for you, and particularly once people have adopted, they never go back. It's about cascading communication from, it's not just one edict coming down from the top to the front lines. It's at all layers of management, and we pursue the same thing on the health plan side. Again, I won't read every one of these bullets here, but the culture of accountability and commitment and pride. You have to want to be better. And you have to want to be accountable in the sense of taking personal achievement in that. And if those goals and those expectations are developed by, again, I'm going to speak within the medical group context here, by your peer physicians and your elected leadership, you own that. You can't complain that, well, health plan's making me do this, or the federal government has put this new thing in there. I mean, we have some of those. But for the most part, they're hitting targets that they themselves have set. And they may be sort of technically difficult to hit those targets, but they're not coming, it's not well, somebody else told me to do this and therefore I don't want to do this. It's being relentless about being focused on what you're actually trying to do. It's, I think we just heard a little bit, whether it's because of political change or other circumstances, but, quality improvement initiatives are like mice. They just proliferate, and you have to try and keep an eye on what are we really trying to accomplish here. Is this we're trying to bring up metrics in for certain things? Can we sequence these? Do we have to do them all today, or can we stagger them out over a couple of years? Continued improvement in the quality of data. Again, electronic medical record systems don't install themselves. They don't maintain themselves. The clinical decision supports have to be updated. They don't always work as you intended them to work, so you have to keep changing them and figure out what it is. We've all heard about alert fatigue. You can't prompt physicians to do something about everything that might come across their desk, because not everything has the same value. That means you have to have a process that says, how are we prioritizing in all of this? And then it's about leveraging the technology we have for personalization of care. All of our members have access. I can't do it on my phone right here because I don't think I have the Wi-Fi set up. But I can get my electronic medical record on this phone in this room, and not everyone has the ability to do that. And I can set my appointments, and I can do all of the other pieces. That's value again to our members and our customers. So you saw a similar chart to this. This one's kind of old, but I used an old one to make a point. Again, it's leveraging unwarranted variation. This one is on hypertension control for a group of 42 physicians, and the performance there ranges from 45% to 80%. And again, I don't know what the right number is, but I'm guessing you shouldn't have a near 2-to-1 variation here, particularly around hypertension. But these are the kinds of reports that we can run basically at the push of a button to see, so how are we doing? And then the question is, once you have this information, what do you do with it? Well, the typical response in our world is those two docs on the right-hand side, their medical leadership might say, why don't you go talk to doctors 1 and 2? What are you doing differently that they're not doing? Right? And it could be, I don't know if these particular data are risk adjusted or anything like that, but it's not a punitive environment, it's a learning environment. And does it matter? This is kind of a hard chart to read, but so the two bars on the left for 2004 and 2005, those are kind of the sort of the global, let me go back one. So 65%, that was our average there. That's not where we want to be. So in 2005, the green here I think is commercial, blue is Medicare. We were well below target. We were below the 50th percentile of where we should be. Boom, put in electronic medical records, start pulling the data, start feeding the data back to the physicians, and where do we get? Now we're sort of the number one performer in the country on this because we collected the data and then did something with it. The environment, and this is just sort of the text version of my bubble diagram. So what else drives value? Well, we have our internal accountability and commitment. Again, we operate in a world where we have to bring people to us, right? So again, different situation than what you're in, but it's a driver for us. If we want to succeed, we've got people out there who would gladly take our business. And so we've got competition on the health plan side, we've got competition on the physician side, on the hospital side. We have regulators setting minimum standards, and as you might imagine, not always consistently. We have accreditors publishing comparative data, and it's really nice when you're sort of at the number 1 or number 2 slot We've upped our expectations. There was a time when we said, well, we want to be at the 75th percentile, and I would think, why would you ever want to be at the 75th percentile? Why wouldn't you want to be number one? We call these the lollipop diagrams. So the two boxes there, one is best care for chronic conditions and a couple of submetrics. The other is on prevention and cancer screening. And the bottom ends of these are roughly 2003, 2004, where we ranked. And I think it was eye-opening for us to find out that, oh, we thought we were way better than that. Well, we weren't. Now roll the clock forward to, I think this is 2014, and the little blue circles at the top. Once we had the data in place and we could set goals for where would we like to be, well, we would like to be at the top, and that's where we've ended up. So I will stop there, and we'll go to questions, yes?
Yeah, just a couple.
Okay.